So just very briefly on RADAR 1, thanks to Dave Crawford's vision, you see the authors here, multidisciplinary group. This was published in Urology in 2014. And what we looked at, many of the authors are in this room today and have been at this meeting, the goal was early identification of metastatic disease. And remember, this is back when we got together in 2013, published in 2014. Newly diagnosed patients, you see the criteria, the biochemical relapse patients or the PSA relapse, and then the M0 or the index case 1 of the AUA guidelines. And so what are the imaging modalities at the time? Technetium bone scan, full body CT scan, and then there was commentary around adding on plain radiography, MRI, not whole body, and sodium fluoride PET, which is now essentially non-existent because of a lack of CMS reimbursement. So the summary of RADAR 1, as you can see here, there was inconsistency in the literature and current practice guidelines in terms of eligibility criteria, type of imaging modality, frequency of scanning. So the challenge there is underdiagnosis of metastatic disease. So then we fall short of doing what's optimal for patient management. There was consensus and recommendations to promote early identification of metastatic disease, and that was the RADAR 1 group. And so we moved to RADAR 2 very quickly. A very similar author group. Again, many of the authors are at this meeting. And the goals of RADAR 2 were now to look at the concepts of sequencing and combining all of the new rapidly approved CRP therapeutics that really came sort of as really a gold rush to so many of us who are dedicated to the space. So how do we combine, how do we sequence, and then this notion, again, thanks to David Crawford, who really has the vision for coming up with the verbiage, and verbiage is important, but we came up with this notion of therapeutic layering. So our conclusions were there remains challenges despite the advancements in therapy. We understand that there are unique and complementary mechanisms, but we want to avoid cross-resistance and mutational aberrations, which ultimately lead to clonal expansions, more tumor burden, and eventually patient death. We want to optimize treatment, clinical trials, strong push for them, absolutely integral. And these are really the basis of our recommendations, as you can see here, both in clinical empiric experience, as well as the trial literature. So then we get to RADAR 3. And so this is the third iteration of the group, many of the same folks, but again, Raul is here, Lenny Gamello, Larry Karsh, Tom Keene, Paul Moroney, Dan Petrolak, and of course with Dave's leadership, and Rob Ryder's at the meeting as well. So this was published in J Urology this year. What were the goals? So understanding the potential use for initial staging of patients with NMCRPC. We had wonderful presentations this morning on this with great discussion already, and understand the rationale for obtaining the different scans, the frequency of ordering, and the results of integrating this in terms of an algorithm. This is really not in guidelines, and those questions that we're pondering already this morning. So gauge the utilization of next generation imaging, how to implement into practice, does a practice impact on adherence? And then there was, again, the concept of considering redefining terminology, moving away from castration to endocrine resistant. I'll show you a slide on that as well. And we updated existing RADAR 1 and 2 recommendations. Phil Koo will be presenting later today and go into much greater detail. This is a busy slide, but looking at the various advancements in PET scanning technology. And again, coming at us with rapid pace. And the U.S. has been historically somewhat lacking. We get the therapeutics approved, we have accessibility, but other parts of the world are actually lapping us in terms of accessibility. And I think it's already been mentioned, hopefully the PSMA gallium scanning will be more accessible in the near term, but we now have fluciclovine in addition to FDG PET, some limited choline PET, and of course technetium bone scan and CT scan. So there's numerous studies that we evaluated and we looked at, and this was a lot of the hard work of the working group. And essentially, most of the data is in the biochemical relapse or the PCA relapse, and these show that there's clear data that many of these newer advanced PET imaging modalities are particularly more accurate and sensitive than technetium bone scan, CT scan. The caveat being interpretability, quality of the study is super important. So we have various scan types. There's a whole list of different coverages. This is for the U.S. And it's always the 800-pound gorilla in the room, and of course it's important that you can order a test, but if it's going to tie you up in pre-authorization or if it's not going to be reimbursed, then it just creates an enormous headache from a practical standpoint. So the RADAR-3. So I mentioned the group discussed this, and it was not without controversy, and there have been other articles written on this and counterpoints, cons, pros, on the use of the terminology. I can tell you that I think most of us find that patients don't like the word you have castration-resistant prostate cancer. And so there was a discussion about potentially refining to endocrine-resistant prostate cancer. This was the feeling of the majority of the working group. And then a build, as you can see in the bottom two bullets, if there's negative conventional imaging, technetium bone scan, CT scan, then there's the consideration for getting novel or next generation imaging, and if it's positive, and then potentially in patients who have symptomatology or don't have symptomatology. So the recommendations that we came across, and I'd strongly recommend that you take a look at the paper because it goes into much greater detail, is that conventional imaging followed by next generation imaging if this conventional imaging is equivocal or negative, if you have concerns following the elevated Gleason score, typically Gleason groups 4 and 5, the absolute PSA level, or the PSA kinetics of doubling time or velocity. And so patients who meet NCCN very high risk or locally advanced, newly diagnosed, should also be considered for NGI because this is a group that potentially could fall into the oligometastatic disease group, or if not, could have combined modalities for better treatment outcomes. Busy slide, but you have it so you can look at it. The blue shows the RADAR-1 and what we did in RADAR-3 in the red boxes, looking at those 3 buckets that we explored in the original paper in urology for the newly diagnosed, the biochemical recurrent, and the NMC-RPC or the M0 space. And time doesn't allow me to go through it, but if you take your time looking through the slide, you'll see where over a 4-year period with the advancements in imaging, with the advancements in therapeutics, we were able to make these additional recommendations. So the additional conclusions of the RADAR-3 is that yes, indeed, conventional imaging, without a doubt, in the United States and throughout most of the world, continues to have a prominent role in diagnosis and for that part in management. But the next generation imaging modalities are clearly more sensitive in visualizing advanced prostate cancer. Early aggressive, and especially if early and aggressive intervention is indicated based on your assessment of the patient's actuarial prognosis. 18 fluciclovine PET is recommended because, at least in the United States, it certainly has most availability and a reimbursement pathway. But the potential, it clearly is there now also for the PSMA gallium scans. Right now there is very poor accessibility, but again, as I think we mentioned earlier in the program yesterday, thanks to, I think, UCLA and UCSF, this might change hopefully by the end of the year and have greater offerings for diagnosticians. So, final conclusion, strong recommendation for next generation imaging in biochemical relapse, but the data is most robust in this particular population, and it brings us to the whole conundrum of localized treatment versus systemic treatment versus combination therapy for what you might find. The limitations, we clearly recognize the lack of prospective phase 3 trial data and also the lack of ongoing additional safety data. The benefits, despite the limitations, we feel in the consensus group we did meet our goals. Early days certainly will warrant additional recommendations pending further studies and the trials that are forthcoming and ongoing, which many of us are participating in now. Thank you very much.